Okay. We are good to go. You know, I'm gonna see. Wonder if I can like make you co-host now. Change. Oh no,
No.
because it says change role to attendee or make host, but like I want to make you a co-host so that if I could put.
Is it something when you make the Zoom meeting, maybe?
So like there's panelist invite and then there's like a co-host invite on the Zoom, and I wonder if they're different links.
Hmm.
But it's given me problems in the past when I've tried to put somebody in as a co-host.
Yeah. I feel like I've run into that before too.
Yeah, I don't, because I remember I tried to make Hal a co-host for his,
Right.
but
That was
then
one.
it like wouldn't, I sent it to him, but I couldn't put in the specific email that I wanted to, so maybe that was the problem, but maybe our next series next year, we can figure out how to do that. All right, people, start jumping on.
I think I have. Oh wait, I have to pull it up. The slide. Are you going to share the slide for
Yeah,
like?
sure.
Okay.
Yeah.
Did you do a feed in the chat, or I'll just pull up an old one?
It's in there. There's just not any links, but it's ready for you. Oh, I should have sent that to you. I'm sorry.
Oh, it's okay. I just was looking at it. The folder was empty, so maybe it just hasn't updated.
Oh, wait, let me look. Hang on. Chat. Okay, here we go.
Yeah, just, oh, am I looking in the training? That might be why.
Hang on. Send you a link. So it just doesn't have anything, and it doesn't have like our next event because we like don't,
It's the end. Yeah.
just that stuff. I'll keep this up just in case anything happens. But standard stuff. I'm like, I was about to say I'm nervous this is the wrong link, but it's not because I have to go on Zoom and like literally click start webinar. So people are just taking their time today, which is fine. Okay. Slide. Okay, let me get this slide up. And then when Dr. Hoops joins, I'll have her just share her slides just to make sure she's good to go. Chat is good so everybody can. I don't like how when I get on, I have to like make sure the chat that everybody can chat with everybody. Because at first it has attendees can't chat with anyone.
Yeah.
I don't know why it does that. Hi, people.
Just have to remind everyone. Usually I got a notification.
Yeah, but I think they typically think it's an hour before. Should have gotten one a week, a day, and an hour.
Oh, we have one person.
Hi, Dr. Hoops, how are you?
Hey, I'm doing well. How are you?
Good. I'm gonna take my slide down for a minute and I'm just gonna have you share your screen just to make sure that's working before we get started.
Perfect.
Have some time. Perfect.
You see slides? They're windowed because otherwise I can't see people and screen.
Yeah,
So,
that's a great
but
idea. No, that's perfect. Thank you so much.
sure. And I don't have anything fancy, no sound, no video or anything. It'll just
Okay.
be slides. And I will admit I have way more slides than I probably have time to get through, but I can kind of lop us off at one point if we want to break for questions. So
Yeah, typically we like to leave like 10 to 15 minutes for questions. We'll monitor the chat throughout and we'll make note of the questions. And there's also a Q&A function where they can submit questions too.
oh,
So
perfect.
we will keep track of that for you, and then at the end, we'll leave some questions.
Cool. And I mean I'll say this too, but if at any point you want to interject questions rather than holding them to the end, because the presentation is kind of divided into epidemiology and some suicide prevention
Mhm.
specifics, and then some safe storage specifics, and there's like a
Okay,
conceptual model or two thrown in. So like if it feels logical to just interrupt
yeah,
and answer a question as we're going, I would
okay,
way prefer to do that than kind of have to go
yeah,
back and
yeah,
recapitulate. So
okay, let's do that. So if we see a question pop up, we'll kind of wait, see if there's a good stopping point in that section,
yeah,
and then we'll kind of jump in and have you answer that question.
perfect. Sounds good.
Okay, wonderful.
Do you want me to take mine down and then you can put your
Yeah,
CME
that
slide back
sounds
up?
great.
Cool. And Grace, I don't, have we met yet? I don't feel like we have.
I think we might have
Maybe
met
at
at a
a community
conference.
event. Yeah, yeah. I
Yeah.
was like, I think you look familiar,
Yeah.
but good to see you.
Yeah, good to see you too.
Just going to, I'm always afraid that little text and email alerts, the sound pings through. So I'm just going to try
No
to
worries.
silence all of the pings.
Yeah. For CME credits, we will be putting the evaluation survey in the chat at the end of the session, and then we'll also send out the survey via email after the session as well. So we'll make sure that you have that, and then we will send CME and CEU certificates out via email by June 21st. And we'll also send you a link to the recording for today's session, the slides and related resources as well. Thank
Perfect. And I
you.
will, and I did, as expected, tinker with my slides as of a
No
few minutes
problem.
ago. So I will send you, is a PDF okay? I'll just
Yeah,
send you
that's
a
fine.
PDF of those.
Thank you.
Yeah,
And we will get started in just a couple of minutes. Feel free to introduce yourself in the chat while we're waiting.
sounds good.
Okay, it is 12 o'clock, so we are going to get started. Welcome, everyone, and thank you so much for joining us. My name is Lily Stavisky, and I'm the Outreach and Training Coordinator for BHIPP. I'll be introducing our presenter for today and facilitating the Q&A that we're going to do throughout the session and set up just at the end of the session. But for those of you that are unfamiliar with BHIPP, I'd just like to provide some information about our program. So Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals to address and manage mental health concerns of their patients. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. And the BHIPP Warm Line is staffed by a team of child mental health specialists, and it's available Monday through Friday from 9 a.m. to 5 p.m. And we will put our phone number and website in the chat for you. It is my pleasure to introduce today's BHIPP Mental Health Crisis Training, Firearm Safety Counseling for Youth Injury and Suicide Prevention, Clinical Strategies for Primary Care, presented by Dr. Catherine Hoops. Dr. Hoops is an attending physician in the Pediatric Intensive Care Unit and Associate Professor at Johns Hopkins Schools of Medicine and Public Health. Dr. Hoops's research is focused on a public health approach to the prevention of firearm injury and violence. She is a core faculty member in the Johns Hopkins Bloomberg School of Public Health Center for Gun Violence Solutions, where she's the director of clinical programs and practice. She conducts research on creating effective policy measures, implementing a trauma-informed approach to care, effectively communicating with patients and families about firearm safety, and improving physicians' education and counseling related to firearm safety. She is a senior JD candidate at Georgetown University Law Center, and she's currently leading 2 federally funded multi-site clinical trials studying the implementation of a comprehensive program for firearm access screening and safety counseling in trauma patients. We are very grateful to have you here today, Dr. Hoops. Thank you so much for sharing your expertise with us during the session, and I will hand it over to you.
Well, great. It is I who is grateful. I really appreciate all of y'all being here. And as the incoming Vice President and President-elect of the Maryland chapter of the AAP, I also just want to thank you guys for the incredible services and support that you provide to all of our pediatricians across the state. Just incredible work that you guys are doing. So thank you. And I'm really happy to be here. I will start by attempting to share my slides. All right, everybody see those? Super, thanks, Emily. So again, we're just going to talk, through some data, through some prevention strategies, but really, please interject, add questions in the Q&A, and hopefully we can just have a nice discussion as this goes through. So again, I'm Catherine Hoops. I have no conflicts to disclose. I do receive funding through the federal government. These are our objectives for today. Again, some epidemiology review. We're going to highlight some specific inequities in violence and injury data. We're going to talk about some risk factors that elevate risk. And then we're really going to talk mostly about overcoming barriers to communicating with patients and families and using some of those clinical strategies to keep kids safe at home. So first up, an irresponsibly fast tour of the 2021 firearm fatality data. So I'll share too that my colleagues in the Center for Gun Violence Solutions every year, when the CDC data finalizes, produces a comprehensive report highlighting the most recent complete year's data. So our full report on the 2022 data will be forthcoming now that that's finalized, and that'll be out later this month. But for the time being, I'm going to focus on 2021 data. So this is actually not from our report, but this is from an image that y'all may have seen from Dr. Lois Lee's New England Journal paper in 2022, showing that for decades, motor vehicle collisions were the leading cause of death in youth. But really since 2017, if you separate out crash-related fatalities from other motor vehicle-related deaths, firearms have been the leading cause of death in youth ages 1 to 24. And I show this graph at the beginning of many talks because this is a graphical illustration of the public health approach in action and in inaction. right? So the decline in motor vehicle related deaths is a direct result of the application of central tenets of injury prevention, right? So think everything from licensing and crash avoidance technology to normative social behavior around distracted and impaired driving, trauma system standardization, access to EMS. And I'll spare you the full Haddon Matrix approach, basically the starting point conceptual framework for designing injury prevention initiatives. But suffice to say that we have data to support the application of those same types of interventions for firearm safety. But all these lines are going to continue to diverge until we're willing to say that you can't leave the gun shop until you provide evidence of proper safe storage devices, in the same way that we're willing to say that you can't be discharged home from the hospital with your new baby until you produce an appropriate car seat. So from here, I just want to review some of that 2021 data, like we said. So first, a couple of pie charts. Contrary to what we see in the media usually highlighting mass shootings and homicide, suicide is the leading cause of firearm death in the US. And about 54% of deaths in 2021 were suicides, and fully a third of those are among a military population. But I also want to highlight, and I'll come back to this later, that the greatest increase between 2019 and 2020 and then to 2021 was among American Indian and Alaskan Natives, among whom we saw a 42% increase in firearm suicides during that time frame. Homicides represent about 43% of gun deaths in 2021. And if I were giving y'all this talk in 2017, I would have said, and for the past 20 years, that homicides have been closer to around 35% of gun deaths. But homicides increased by 35% from 2019 to 2020, and again by 9% from 2020 to 2021. So now they occupy a wider slice of this pie. Those smaller sections up at the top represent about 4% of gun deaths, about 1,500 deaths per year, which are unintentional injuries, undetermined intent, and legal intervention or officer-involved shootings. And I'll flag that we don't have a good system for capturing officer-involved shootings as a distinct subgroup, so most of those are included as homicides. Our best available data set, which is actually the Washington Post tracking these events, suggests that that's about 900 to 1,200 deaths per year. So definitely, a gap in our current data collection tools, and hopefully something that will change over the next couple of years. Mass shootings are defined by the Gun Violence Archive as shootings involving 4 or more people, not including the shooter. And those account for about 2% of firearm deaths, and those will be included among homicides or suicides as appropriate here. This next pie chart, and one other thing that I wanted to demonstrate here too, right, that the total number of firearm deaths in 2021, 48,830, right? That's the largest number ever recorded in the US. And then if you zoom in on deaths among young people under 24, so a relatively small segment of the population, 39,807. So a really disproportionate burden of injury among young people. And especially as pediatric clinicians, this is a really, really important perspective for us to consider. So this again shows the number of firearm deaths among people under 24. Here, you'll notice that the majority of gun deaths among young people are homicides rather than suicide. But as y'all know, right, there have been some really important and disturbing trends in suicides among our younger patients, as many of y'all have likely experienced in your clinical practices. In these next couple slides, I want to zoom in on some individual level characteristics. So we spoke, in the previous transition between those two pie charts about the disproportionate burden of injury among young people. And you see that here in this pie chart, which is just crude numbers of deaths by age group throughout the life course. So, here again, showing that increased level of risk, especially from, 15 to 19 up to about 35. And I show this because this is really important to how we design clinical programs. And, especially for our hospital violence intervention programs, those are the ages that we target for enrollment in our hospital-based programs. So again, we can use this data to inform our interventions so that we're guided by the data and guided by the evidence and what we know can be impactful. This next slide shows sex, and I'll add that the reporting system for whiskers for the CDC currently only includes sex assigned at birth. So there is a gap, of course, in how we're collecting this data in the current iteration of these reporting systems. But 87% of firearm suicide victims are male. They're 7 times more likely to die by firearm suicide than females. 84% of firearm homicide victims are male, 5 times more likely to die than females. The difference here, the one kind of distinction in these gender differences, is that females are more likely to be killed by intimate partner related homicide. But of course, again, one of those individual level characteristics that's predictive of risk among our male patients. And race, right? I just want to take a breath, take a beat here for everybody to kind of absorb this. We all know, and we see in our practices, that Black Americans, especially young Black men, are disproportionately impacted by gun violence. And, we see this stark difference, maybe 10, 20, 30 times greater in some cities, difference in homicide rates among young Black men as compared to age-matched white counterparts. I also want to highlight on this graph, though, that increased risk among American Indian and Alaskan Natives, high rates of both suicide and homicide as a population subgroup. I'll also highlight, too, that increased risk of suicide among white Americans. So I think there's important things for our clinical practice that we can take away from different aspects of this data, too. So I think, we could spend the entire hour, talking about those disparities alone. But, suffice to say, we know that individual level factors play a huge role in gun violence. Age, race, gender, and community characteristics matter here too. So, we talk a lot about means matter, and we'll come back to that, but location matters too. So one, gun injury is an everywhere problem. This is not an urban, suburban, rural problem. But I do think that some people are surprised to see that there is a less stark difference between urban and rural communities in terms of homicide rates, but perhaps even more so to see that the significant difference in risk of suicide between urban and rural communities, with higher risk in rural communities, actually drives a higher rate of firearm deaths in rural communities overall. So some of this may track with reduced availability of mental health services in rural communities. Really, again, testimony to the important work that y'all do. But it's also contributed to by prevalence of firearm ownership. And so we're going to come back to some of these factors later on in the talk. And before we summarize some statistics and look more closely at suicide in particular, I just want to highlight this about homicide, right? When we look at homicide in the US, for non-firearm homicide, we're about the same as our peer nations. But firearm homicide really separates us and is 25 times higher than that of our economic peer nations. And this gives us an overall homicide rate that's 2 to 3 times higher than our peer nations. And the availability and lethality of firearms fuels our country's high suicide and homicide rates. And again, I can't say this enough, right? 2020, it brought the highest number of gun deaths in history and the highest proportion of homicides by firearms in history, up from 68% in 2011 to 79% in 2020. I'll highlight, this is an infographic from that annual report that I mentioned, and the 2022 report is forthcoming, but just to highlight a couple of key points of data that we just summarized. 48,830 lives were cut short by gun violence in 2021. Again, the highest number ever recorded in the US. This was largely driven by an increase in homicides, but suicides also increased. Gun violence, again, can't say this enough, disproportionately impacts Black Americans, such that Black teens and young men ages 15 to 34 account for 2% of the population and 36% of all gun homicide victims. But, and we'll come back to this later too, policy really matters, right? People who live in a state with more protective gun policies are less likely to die by gun violence, right? So we contrast on this infographic, Mississippi versus Massachusetts. So in Mississippi, someone is 10 times more likely to die by gun violence than someone who lives in Massachusetts, a state with more protective gun safety legislation. And again, as pediatric clinicians, firearms are now the leading cause of death in children under 24. From here, I want to zoom back in on suicide. And again, we mentioned means matter, locations matter, all these factors. But again, I really want to focus on means here. And I think this will inform some of our subsequent conversations about my research and on counseling. But again, something to keep in mind when we're thinking about suicide is that firearms represent a small portion of overall suicide attempts, right? The overwhelming majority of attempts are by overdose, shown there in blue, and only a small section of this pie is firearms, 6% there shown in green. But because of the sorry, there we go, not advancing. Because of the high case fatality rate in firearms, 85, 90% case fatality rate when a firearm is used in a suicide attempt. In contrast to about a 3% case fatality rate for overdose or ingestion, we then see that firearms account for over half of fatal suicide attempts when they represent just a small portion of overall attempts. So again, access to lethal means really matters in this context. I also want to highlight one other really important health disparity here. So this is an infographic again from our most recent paper showing, or for the 2021 paper, showing the increase in percentage of Black high school students seriously considering suicide over the last several years. And I probably don't need to show this to this group, right? Because we've seen this in our clinical practice. I also want to highlight specifically, again, something that we've probably all seen in our clinical practices, that particular increase in suicide risk among Black LGBTQIA youth. And again, I present these data because they frame why the policy initiatives that I'll describe are really important means of addressing specific risks. So these data are from the AFSP and CDC, as well as the Youth Risk Behavior Survey, showing that while suicide deaths among youth are unacceptably high, the majority of suicide attempts are not fatal. They present an important opportunity to intervene. And people who attempt suicide do not go on to reattempt often, nor to die by suicide. However, that presentation, or kind of the pre-presentation, is a really critical point at which to target resources and services. And again, because of the recent increases in suicides and homicides that we've experienced over the last couple of years, we tend to focus on recent history. But I want to highlight here that suicides have been increasing for the last 20 years after that initial decline with the introduction of SSRIs, such that the crude rate in 2021 was 14.5 per 100,000 and 14.9 per 100,000 in 2022. And then I want to zoom in again on some of those important individual level characteristics specifically for suicide, right? That suicide deaths occur primarily among males, especially among white males, but the age-based rates here really are critical, right? Suicide risk peaks for Black and AIAN youth at age 20, but for Hispanic and non-Hispanic whites at an age closer to 80. So again, a really important opportunity to intervene, especially for us as pediatric clinicians. Because some of these risk factors are fixed, but others are modifiable, right? We can't change being white, being male, but of course we're wanting to intervene to address those structural political determinants of health that drive risk among marginalized populations. But many of these risk factors, specifically access to lethal means, are modifiable. The next two slides are maps of rates of firearm deaths in the US, again, highlighting that policy matters, and something that we'll come back to in the last section if we have time. You'll want to give time for questions as well. But again, this map shows that the darkest states represent those with the highest age-adjusted rates of firearm deaths. And then the subsequent map shows the same data for young people under 24. And I know what you're all thinking. Hold that thought, and we will develop this a little bit later, but I just want to show this to contextualize some of the data. And, we've talked a lot about, firearm fatalities and mortality data, but I can't not say, that these are individual injuries with really broad effects, right? That we're losing 134 lives every day to gun violence in the US. And that's having myriad, immeasurable impacts on families, communities, and there's also the incredible mental health toll on the individual and their communities. With mental health impacts, I know this data will differ depending on the source, but in our patients specifically who are individually affected by gun violence, that we see acute stress disorder in up to 35% of those patients. We see PTSD in anywhere from 5 to 40% of those individuals, depression in up to 36%, and substance use in about a third. And I never like highlighting financial information here, but when all of this data doesn't compel people, sometimes maybe the dollars will, and the impact of this is extraordinary, right? That it costs us about $230 billion every year just for healthcare costs, lost income, employer costs, legal costs, not again including the myriad other impacts well beyond in people's communities. But our interventions really matter. And this is specific to hospital violence intervention programs, kind of a clinical program that's really important to me, although not something that we're going to spend a tremendous amount of time here. But I do just want to highlight the opportunity for clinical interventions, right? That, on meeting a patient for a firearm injury in the hospital, we are assault-related injuries. We are able to connect people with resources in the hospital, wrap around case management and mental health services and social work to try to help interrupt that cycle of violence and interrupt future pathways to re-injury. And we see from our data in Baltimore City that prior to implementation of hospital-based violence intervention programs, we saw, similar to national trends, about a 16% rate of trauma recidivism. I don't really like the term recidivism, but a traumatic re-injury rate among people who are admitted for assault traumas. But I show this because I really want to highlight some recent kind of hot off the press statistics for our programs that now for the last year, in the last 12 months, among our clients being seen by our hospital violence intervention program, we have 0% re-injury rates. So again, clinical interventions and connection with resources really, really matter and are incredibly impactful. I want to talk next just about a couple of conceptual frameworks because I think they kind of help to guide some of our prevention strategies. And first, I like to show this because I think we talk a lot about, what is the public health approach to violence prevention or to anything, right? This can be for anything from violence prevention to, infectious disease. But what really is that? And it's pretty simple, but I think this is helpful to kind of show as an illustration. So first, right, we're working to understand the burden of the problem. What's the scope? Then we explore, based on that data, its root causes and protective factors. And then we develop interventions and figure out what works and for whom. And then we scale up the effective stuff and reiterate the cycle of studying, how that scaled up intervention then affects the burden of disease. And I think this is helpful just to share as a conceptual model for how we're thinking about all the interventions that we're doing, continually evaluating and reevaluating the interventions that we're doing. Another conceptual model that I want to highlight is the social ecological model. And this is the model that CDC uses for violence prevention initiatives. And I really like this illustration of the model too, right? This considers individual, relational, community, and societal factors and helps us to consider the range of those factors that put people at greater risk for violence or protect them from it. And you'll notice how the domains overlap, right? I think this illustrates how community level factors influence individual level factors and so on, right? And that overlapping also helps to show that it's important to act across multiple levels simultaneously to create sustainable and effective interventions that can reach entire populations. So some of those individual level characteristics are the ones that we were talking about before, right? Age, gender, but education, income, and individual history of abuse. And the prevention strategies then are guided by those individual level factors that might include conflict resolution training, social emotional learning programs in schools, and safe dating education programs. The relationship level considers influences among an individual's closest social circle peers and family. And so those kind of interventions might include parenting programs or mentoring, peer support programs, or those that promote positive social norms in individual relationships. The community level explores the environments in which those social relationships occur, right? Schools, workplaces, faith communities, neighborhoods. And prevention strategies focus on improving the safety and strength of physical and social environments that promote neighborhood safety and engagement and reduce factors that contribute to violence, like poverty, blight remediation, housing instability, and residential segregation. And then the fourth level, that societal level, consider those broader factors that contribute to violence. This level emphasizes policies that can reduce structural determinants of health and inequity. And I add these because I think these really help to inform how we think about some of our clinical strategies for prevention. But I will just show one more conceptual framework once we start that, before we start that little section. And so first and foremost, I'm sure this is a conceptual model, maybe an image that's familiar to all of y'all, but we want to be creating trauma-informed systems, and what really does that mean, right? So in simplest terms, it's recognizing that trauma is ubiquitous, among our patients and their families, but also among our colleagues. And so, being trauma informed means recognizing that when a patient responds in a way that you didn't expect, instead of, and I think probably we often say this, right? Instead of asking what's wrong with them, you create a safe space to process what's happened to them. And I really strongly believe that we all, in all of our clinical disciplines and all of our clinical settings, have roles in creating compassionate and safe environments for our patients. And I think that it starts with educating ourselves about trauma and stress and being attuned to those factors in ourselves and in our partners and colleagues too. Okay, from there, I won't spend too much time on trauma-informed care. I know you guys do a lot on trauma-informed care and resources, but next I want to delve into lethal means safety and safe storage counseling in particular. And I already gave a quick, oh, there we go, not advancing, the quick preview of the pyramid. But what I think is important for people to know about safe storage is that it's progressive, right? That the foundation is safe storage, and with increasing levels of risk, increasing levels of protection have to be conferred. So I got a media request recently about a statistic on firearms used in youth perpetrated mass shootings. And the reporter queried whether it was accurate to say that 70 to 80% of firearms used were not secured, when the data show that some of those firearms may have been in safes or secured with a cable lock. So weren't they then secured? And my response is no. If an unauthorized user accesses a firearm when they were known to be at risk, then the firearm wasn't sufficiently secured. So again, basic safe storage is the foundation, but increasing levels of security have to be implemented when there are at-risk youth or adults who could gain access to highly lethal means. So what then is that next step up, right? So in the ideal world, we have this foundation of talking about safe and secure storage in our primary care settings. We'll come back to some of my work on that counseling and concept later. But so maybe we have this foundation of talking about the baseline safe and secure storage, the logistics of which we'll also come back to. But then, what if someone is at higher risk for suicide or for interpersonal violence? That might be when we're thinking about, or that is when we're thinking about doing specific lethal means safety counseling. And so that's assessing whether an individual is at risk for suicide and whether they have access to firearms or other lethal means. So, then clinicians can work with them and their families to support limitations in access. So for firearms, this might mean a voluntary transfer to a trusted friend or relative. This might mean transferring the firearm to an offsite storage facility, such as, and I'll highlight on the Marylanders to Prevent Gun Violence website, we have a Maryland Safe Storage map that highlights different firearms retailers and law enforcement agencies that offer offsite storage. Sometimes that's something simple like a locker, where you can go and lock up your firearm out of the home. But sometimes it looks differently depending on the site. But again, maybe that's transferring or taking your firearm to a gun shop or range or law enforcement facility where you can get the firearm out of the home when you have someone at risk. And really, again, conceptualizing and specifying risk and why these behaviors and changes and higher levels of protection is so critical, right? owning a firearm doesn't cause mass shootings, doesn't cause suicidality, but it does increase risk, right? As we all know, suicide crises are often short-lived, but they're really powerful impulses, right? We know that 75% of suicide attempts occur less than an hour after making the decision to attempt. And so owning a firearm and having access to highly lethal means increases the risk that if they do experience a crisis, then that impulse might result in their death. And having access to a firearm in the home does increase the odds of suicide by 3 times. But an abundance of research shows that method substitution is unlikely. So even if they were to attempt using another method, those methods are often less lethal than firearms, and their odds of survival and then connecting with resources are higher. So that's kind of the general conceptual framework for lethal means safety and counseling, interrupting that pathway from ideation to attempt by restricting access to highly lethal means. But what if you need a higher level of protection even than that? That's when you might be thinking about an extreme risk protective order, shortened for the purposes of my pyramid and character restriction there. But extreme risk protective orders are essentially kind of the most restrictive means of lethal means safety counseling, right? These are reserved only for individuals at imminent risk, at greatest risk of harm to themselves or others. And, again, safe storage is the foundation. All firearms should be stored unloaded in a locked cabinet or safe, maybe with an external locking device additionally. All of these should be inaccessible to children. But for those at highest risk, ERPO can be considered. And so in some states, Maryland in particular, and I'll zoom back in on this in the policy section subsequently, but clinicians can petition directly. But in all states that have them, that's 21 states and DC, clinicians can work with law enforcement or potentially a family member in some of the newer iterations of these policies to implement ERPO. And what really is an ERPO? ERPO are civil dispossession orders, by which you can petition the court and petition law enforcement to remove firearms from the home of someone who is at imminent risk of harm to themselves or others. We'll come back to more logistics and specifics about ERPO subsequently. And then at the peak of that pyramid, you'll see, of course, EPs or emergency petitions, again, character restricted by my pyramid design here, but those are only used when an individual is experiencing a psychiatric crisis and can really only be made if the petitioner has reason to believe that an individual has a diagnosable mental illness, or I'm kind of reciting some statutory language here, but diagnosable mental illness, and that individual presents a danger to their own life and safety or that of others. And so I put EP at the peak of the pyramid, because even though I just said that ERPO is the most restrictive means of lethal means safety in terms of restricting access to lethal means, of course, EPs are the most restrictive, in terms of just one's general civil liberties and the most restrictive intervention that we can prescribe. But of course, recognizing that these are an important part of this hierarchy, because in many cases, these are life-saving and necessary. But used, again, thoughtfully in combination with all of these other factors. Okay, spent a lot of time on that slide, but I want to highlight now, what, again, safe storage is, because I think, there's a lot of ways to think about this. One, on top of the fridge is not safely stored, no matter what, my grandparents thought. But it's a hierarchy, right? So the bare minimum is that firearms are stored unloaded, but increasing levels of protection are conferred by each of these subsequent interventions, right? So unloaded with an external locking device, like a cable lock, unloaded with an internal locking device, like an internal barrel lock, unloaded in like a drawer safe that's movable, right? And then the gold standard is that yellow box over there, that they're stored unloaded in an immovable safe, right? Like a bolted down drawer safe or a big cabinet that couldn't feasibly be moved. So I highlight these, right? That this is, again, increasing levels of protection. And in our counseling, we always want to be starting with that gold standard, but I also want to highlight, that we shouldn't allow perfect to be the enemy of good. And so if I can talk to a patient and family and they're willing to adopt a cable lock or a drawer safe, right? I'm not going to let that immovable wall safe stand between me and some level of protection when the other option is on top of the refrigerator, right? So again, this is intended to be a patient-centered, family-centered approach to arriving at these safe storage measures being adopted. So this next slide is, again, highlighting some of these lethal means safety options, and I'll highlight in some of those subpoints a couple of specific research projects that we're working on. Again, safe storage is the foundation. Lethal means safety might include offsite storage or voluntary transfer. If you need a higher level of protection than even that, then you're talking about extreme risk protective orders. I'll hopefully have time to talk about our Gun Violence Navigator project, and then ultimately most restrictive involuntary admission. And, I want to, there we go, one animation. Want to highlight a little bit of data from a couple of studies in pediatric emergency settings, right? That really a small number of clinicians have been trained in providing lethal means safety counseling. And, a highlight here, right? So from record review, in a year of pediatric psych ED visits, only 11% of patients were screened for firearm access. But of those screened, almost 20% did endorse access to firearms. So we really need to be thinking about these risk strata and then our likelihood of having firearm safety discussions. I think this is really important data that we need to use to inform more clinical educational programs and program development, because families want to hear from us on this, right? I put this quote here from some work that one of my colleagues did, right? Among psychologic autopsies of survivors of suicide, family members of a suicide decedent, young people ages 15 to 21 in particular, that, many of us, even we're not having these conversations. And, 83% said they would have filed an ERPO if they were aware of the law. And I highlight this quote, and I'm just going to read it to you because I think these words speak volumes, and they will always stick with me, right? If someone would have just suggested, you might want to take the guns out of the house, that's what we would have done. But we just didn't think, And so I think that's where we come in as clinicians, right? That we need to be personalizing, tailoring, engaging in patient-centered counseling, and really focusing in on specific risk factors and why we think these interventions matter and can be life-saving. And to that end, some of the work that I get to do with my colleagues here, we're leading 2 multi-site clinical trials on developing universal firearm access screening and counseling programs. And this is specific to trauma centers, but really, the conceptual model, I think, lends itself to subsequent study and implementation in a variety of settings. But right now we're starting with trauma centers. One, because we have kind of the luxury of time during an inpatient admission, and also the other injury prevention mission of a trauma center, both pediatric and adult. So again, these are 2 multi-site clinical trials, a national cohort of 3 pediatric trauma centers and a regional cohort of adult trauma centers, where we'll be screening all trauma patients for access to a firearm using a single question screen. Do you happen to have in your home, car, or garage any firearms? And then for all those patients who screen as having access to a firearm, we'll be delivering counseling using a structured framework. Actually uses the 5 A's approach, with which you may be familiar. We use this for smoking cessation and weight loss counseling, and it's one of the endorsed models by SAMHSA, but we'll be applying that to firearm safety. And really, the first A, I think, is the most important. Ask more questions. So the 5 A's are ask, advise, assess, assist, and arrange. And so ask more questions. Seek to understand why a patient has a firearm, what kind of firearms they have, why they want to store it in the way they currently have it stored, and then work together to figure out how they can adopt a safer health behavior change. And so our goal with this project is to, again, develop a process that works, that can be scaled up to other settings, so that we are working together to improve clinicians' credibility as messengers on firearms and firearm safety. And also really encouraging clinicians to engage in more nuanced, more patient-centered approaches to firearm safety counseling, right? Like, one size does not fit all here. That immovable wall safe in the basement is not going to work for everybody. And so, really tailoring this counseling for, with a family-centered, trauma-informed approach, I think is critical. And I'm happy to come back to some of these strategies later. But I do want to come back to some of those policy strategies and talk specifically about ERPO, because I think that's important, especially for us as Maryland clinicians. So again, this is that graph, or this is that map of youth firearm deaths by state. And I'll highlight first child access prevention laws by state, right? So if you go toggle back and forth between these, it's like inverting a chest x-ray, right? The states that have cap laws have lower rates of child gun deaths, right? And you know, that makes sense because we know that restricting access to firearms can help to prevent injuries, especially among youth. So sorry, that's a lot of words on that slide, but you know, we know that 1/3 of homes with children have at least one gun. We know, again, firearms are used in over 40% of fatal suicides among those aged 13 to 17. Often, those are being attempted using a gun that belonged to a family member or friend. But we also know that safe storage reduces injury, and safe storage laws really go a long way in reducing gun deaths, especially in youth. I also add, because even if, you know, there's not an at-risk person in someone's household, or, you know, whatever else might not have been compelling, sometimes I think this statistic on theft is really compelling, right? Nobody wants their gun to be stolen. Nobody wants their gun to be used in a crime. No one wants their child to be injured. No one wants anyone to be injured using a firearm too. But again, I share this as something that's sometimes helpful for me counseling on safety. And first, this is absolutely an underreport. This number is higher than this, but at least the best available data that we have is that 200 to 400,000 firearms are stolen from homes and vehicles each year. And this is a really important portal of entry for crime guns. And so safe storage not only prevents suicide, homicide, unintentional injury, it also is protective against firearm theft, and which I think is really compelling and important information for a lot of gun owners. Okay, next, as promised, I want to talk about extreme risk protective orders, right? So, you know, these have really expanded in the last couple of years, right? So again, they allow individuals to petition the court to dispossess someone at imminent risk to themselves or others of all firearms, right? So again, all states that have them, again, 21 states and DC, allow law enforcement to petition, but those newer versions include clinicians as petitioners or family members as petitioners. And you know, some of the counter that you hear sometimes to ERPO is that there isn't due process, that we just petition the court and then they take all the firearms, but that's really not how it works. There is due process. So yes, for the ex parte hearing, the respondent may not be present for that initial emergency order, but within 7 days, there is a final order at which the respondent does receive notice and is able to present their case. And the final order isn't always issued, right? So there's judgment, there's a presentation of evidence that has to demonstrate that a person is at imminent risk of harm to themselves or others in order for that ERPO to be initiated. And I'll show some of the specific language in the Maryland statute on the next slide. Again, it's also only temporary. If the order is issued, it usually lasts for a year, but it can be removed sooner if that critical time period passes sooner. It can also be extended for, you know, set durations if the critical time lasts longer. And you know, I'll highlight here that, you know, law enforcement initiated ERPOs are supported by about 76% of US adults, including 65% of gun owners. But family initiated ERPOs are supported by more than 80% of adults, including more than 70% of gun owners. So again, this is you know, an important potential policy intervention that we can use as clinicians in the state of Maryland to help to protect some of our most at-risk patients. And you know, this data is compelling. I share this statistic a lot from some of my colleagues at Duke, showing that for states that have had them longer, notably Connecticut and Indiana, there have been substantial reductions in suicide. And I love this statistic. For every 10 ERPOs implemented in these two states over a period of time, 1 suicide was prevented. That's a number needed to treat of 10. And that beats the socks off of a lot of the stuff that I do on a day-to-day basis as a clinician in the ICU. So again, this is a really effective policy intervention that we have for our most at-risk patients. You know, we also see that these are talked about a lot as, you know, red flag laws in the context of fatal mass shootings. And, you know, even though mass shootings feel incredibly common. They are statistically rare events. So showing that something is effective in preventing mass shootings can be really challenging. But these have been shown to prevent fatal mass shootings, and so I think again a really important policy that's available to us for at-risk individuals. I share this, and I apologize, that looks a little fuzzy here, but this is from the ERPO National Resource Center. Can be found at erpo.org. Apologize, no link, no QR code to it, but I think you can remember it, erpo.org. That's the ERPO National Resource Center that my colleagues in the Center for Gun Violence Solutions, together with partners in the Department of Justice and the Bureau of Justice Assistance, produce to support implementation and policy making around extreme risk protective orders in all the states that have them and those that are seeking to implement an ERPO policy. So it's an incredible resource. I commend you to the site if you're interested to learn more. There are state-specific toolkits and guides, information about legislative history, specifics about your laws, and one of the nice kind of consistent themes here is that they have a little table that shows specific provisions in each state. And so this just breaks out, what the ex parte order is, how long it lasts, what the burden of proof is, again, like what level of evidence you have to demonstrate in order for the ERPO to be issued, the factors to consider, again, the specific statutory language that has to be considered and supporting evidence presented for, and who can petition in each state. So again, I think this is helpful. In Maryland, we have the option for clinicians to petition directly, and this just shows kind of the policy landscape and how these work.
Dr. Hoops, we have two questions for you.
Oh, great.
So first one is, for families struggling to combat poverty, what low budget safe storage recommendations do you have?
Oh gosh, I'm so glad you asked this question. So cable locks are the least expensive option, right? You'll remember that those were not in the gold standard box, but those are available for about $5 to $10 each. But you can get those for free through Project Child Safe, which has partnered with many law enforcement groups across the state to get those for free. Or I'll also highlight that there are also opportunities to partner. My organization in particular is looking to partner with the libraries and other primary care practices to support distribution of safe storage devices. So just kind of the range of options. A cable lock costs about $5 to $10, and a drawer safe with a key costs about $25 to $35. A drawer safe that's a quick access key code or biometric code, that's usually in like the $50 to $100 range. Amazon Basics actually makes one. Amazon makes everything. But there's a lot of variability. The California DOJ actually certifies a lot of safe storage devices, and so that can be a helpful resource on like what's a high quality device. But in general, that's kind of the cost range. We do know that the most effective interventions around safe storage do provide free access to safe storage devices. So if it's an option for your practice to purchase 100 cable locks or something and give those out to patients, that can be really helpful in adopting a health behavior change, and can also open a conversation about buying a more protective device like a drawer safe. But yeah, that's kind of the cost range on those. And I hope to be able to share with you guys in a few months resources for accessing safe storage devices in the libraries. So
great, thank you. Next question is, not long ago, a 6-year-old took a gun from home to school and shot their teacher. Aside from safe storage, what opportunities do you see for elementary school related education for children and their families?
Oh, yeah, a great question with really a really hard and complex answer that I don't know that any of us really have. But safe storage, I think, again, is the foundation, right? If that firearm were inaccessible, that event wouldn't have happened, right? If that were in a safe to which a child didn't have access, that interrupts, again, that pathway, right? From I'm going to go show this to my friends at school, you know, that would have interrupted and potentially prevented that event, right? I think that by engaging in patient-centered counseling, we also open the door to having more conversations about, you know, firearm access and ownership. But I think, you know, I wouldn't, even though for a long time the guidance was, you know, that the safest home from firearm injuries is a home without firearms, I wouldn't suggest that as a starting point, right? I think I would start with, you know, you have made this decision because you think that this is helpful to protect your family. And I want to help you keep your family safe too. And so, you know, having a first conversation about safe storage that honors, you know, their decision to own a firearm and have a firearm in their home, I think can often provide kind of open a door into a broader conversation about firearm access and ownership and thinking about risk more concretely, right? I think that if a family thought that a child could and would gain access to a firearm and use it to hurt somebody else or themselves, they would do everything they can to try to mitigate that risk. I think by and large, right? I think I would adopt that as a general rule, right? You know, certainly we can think of some recent examples where, you know, maybe strong enough action wasn't taken to do that. But I think in general, people want their kids to be safe. And I think that we can provide education and support to help them adopt behaviors that will also keep their family safe and do so in a way that that is more in partnership and less prescriptive, I'll say. I hope that answers the question. It's not a real solution, but I do think, you know, again, safe storage goes a really, really long way in preventing events like that.
Thank you.
Mhm. Next, and I'll go quickly through this because I'd love to be able to get to more questions at the end. But I did just want to highlight some work that I and my colleagues did shortly after the Maryland ERPO law went into effect with the clinician petition in 2018. And so we surveyed a bunch of clinicians and said, hey, what do you think about this? And they're like, what? didn't know what ERPO was, didn't know how to petition for it. But then once you provided them with a little bit of education, like, oh, wow, that sounds time consuming. And, you know, so time was a huge barrier to ERPO implementation for a lot of clinicians. So then that kind of got the wheels and gears turning about, okay, how do we support clinicians to use this really effective tool? And, you know, so through this survey, we learned that clinicians thought that having a coordinator to complete and follow through with petitions would be extraordinarily helpful, right? That provides expertise on, you know, who's eligible, how might that look, how might that work. And, you know, I was informed by my experience with child protection teams, right? So child abuse consult services that we have in the hospital where you have a specific dedicated expert team that then can liaise with the court system and law enforcement moving forward. And so we tried to learn from that model to propose a safe storage gun violence navigator. It's had a few names at this point, but we've just hired 2 full-time social workers through BCRI to be available for consult for ED clinicians and clinicians in other units, as well as eventually outpatient providers who can help to support clinicians do direct patient risk evaluations. And then based on that risk assessment, then they can provide an individualized intervention, right? This person may not be sufficiently high risk to qualify for an extreme risk protective order, but they can still support a family in considering safe in-home storage, including the funding also supports bringing quick access keys, key-coded safes and installing them in people's homes. Also, they can provide counseling on out-of-home storage, private or public, again, using that safe storage map. Or ultimately, if someone is at highest risk, but don't necessarily meet criteria for emergency petition or are kind of at discharge from a mental health admission, then you might be considering an extreme risk protective order, and in which case these navigators would actually submit the petition and attend the various court hearings required for that. And I'll say here that this is not currently available for pediatric patients, but we hope that as we learn from this process in adult patients, that we will expand this to pediatric clinicians and pediatric care settings. And I will definitely share that information with this group when that does become available. But I do think that this model will be really, really helpful in supporting clinicians doing lethal means safety counseling and potentially engaging with the IRPA process. Because, you know, good policy is great, but implementation matters a lot. It matters more, right? If you have good policy, but you don't have good implementation, it's kind of for naught, right? So, you know, we have laws that require safe and secure storage, but if gun owners are unaware of those or the protections that they confer, then they may not be adopting those behaviors. So, or, you know, if a family wants to protect their at-risk youth from harm to themselves or someone else, but they don't fully understand, how to implement these, why they're important, what their options are, then they aren't able to implement them, like that incredibly poignant quote that I showed you on the previous slide. So, our engagement in safe storage counseling, lethal means counseling, just in firearm safety space in general, I think is critical for protecting at-risk youth by helping families to make better informed decisions about guns and gun safety. Okay, so real quick, a summary. I told you what I was going to tell you. I'm going to tell you what I just told you, and a few of these things I've said a few times because I think it's super important. But again, firearms, leading cause of death in youth in the U.S. Safe and secure storage means keeping all firearms unloaded in a lock safe or cabinet and or with an external locking device that's separate from ammunition. But don't let perfect be the enemy of good, right? Partner with families and help them to adopt an intervention and a safe storage behavior that makes sense for them, because safe and secure storage prevents unauthorized users from accessing lethal means. And again, safe storage has been shown to prevent suicide, homicide, unintentional injury, and theft. And with that, you have my thanks and an invitation to questions, either now or by email. You can reach me directly. You can peruse all of the resources that are available on the Center for Gun Violence Solutions website. And of course, you can follow along on X or Instagram as you're interested. The center's Instagram account is great. They share a lot of really helpful, timely information, infographics, and support there. So I would just commend you to those resources. And again, thank you.
Thank you so much, Dr. Hoops. I think we have another question just popped in for you.
Great.
Kids are very curious and excited to see firearms, as it largely is glorified by our culture and reinforced through video games, movies, etc. What do you recommend regarding literature to help children learn more about the dangers of firearms?
Ooh, for kids specifically, not parents, I'm assuming. So this is potentially an area of need, right? I think that, we've come a long way since, some of the NRA's public education campaigns trying to educate kids about, if you see a firearm, don't touch it, tell an adult. But I think we as pediatric clinicians know that kids are curious, right? And they're gonna touch that thing whether or not Eddie Eagle told them not to. And so I think partnering with families, especially for younger age kids, right? I don't think that there is an educational program that adequately protects younger kids from risk, because I don't think that they're developmentally able to do a risk calculation, right? Now, if we're talking about older kids, adolescents, then I think there's some good resources through Project Child Safe, which is affiliated with the National Shooting Sports Foundation, which does provide some education for teens and young people, as well as through some research that my colleagues did with 4-H, called Guardians for Health, that helps to train kids not only on firearm safety that they might have been receiving through their 4-H participation anyways, but also helps to empower them to be active bystanders, to recognize mental health crises in their peers, to help connect them with support, to identify adult mentors who can support them in this. So I think that, 4-H is potentially a great resource depending on your community. And I think Project Child Safe also has good resources for teens. But ultimately, for a younger, for an elementary school age cohort, a toddler age cohort, I don't think there is adequate education that can really help to overcome that developmental barrier to an informed risk calculation. I think then we're really talking mostly about partnering with families to keep kids safe.
Great. Thank you so much,
Yeah.
Dr. for that wonderful presentation, and to all of our participants in today's session. The recording for today's session, the slides, and a list of related resources will be available on our website next week. We will send CME and CEU certificates to participants by June 21st. Just please remember to take the survey as you exit, as this is required if you'd like to receive CME or CEU credit. We will also send it to you via email after this as well. And stay tuned for future BHIPP trainings by following us on our social medias. And thank you again, everyone. And I hope you all have a great rest of your day.
Thank y'all so much.
Thank you. That was wonderful. There was also another comment in here
Oh, yeah.
from a provider in the chat that I just wanted to draw your attention to. She said, it just went away. They said, as a Balto native African-American pediatrician practicing for more than 40 years in the inner city, we must address the hopelessness of Black males as a driver of gun-related deaths and non-fatal shootings. And I would love to see a deep dive presentation on analysis of this patient population and ways that educational and healthcare systems can work together to restructure themselves to address the needs. So I just wanted to read that comment to you.
Oh, absolutely. Yeah. And there is, some of my other colleagues in the center are doing, really important community engaged, youth engaged work that, is aligned with this participant's comment for sure. But absolutely appreciate that comment very much.
Well, thank you so much again.
Great.
Really appreciate it.
Yeah, awesome. Really appreciate y'all. And thanks for the opportunity to talk to your group. I appreciate it.
Thank you.
All right. Y'all take care. Thank you.
Bye.
Bye.